Courtland Hospital Vice President of Population Health, Dr. Courtland Keteyian. Welcome back to the show.
Thank you.
And Courtland loves anniversaries, or I don't know, the cake, because we did a little research, and you were here on JTV's 22nd anniversary.
That's right. I was remembering the montage. Yeah.
Just a few months ago.
Yeah,
so,
that's right.
Yeah,
it's cool.
We appreciate that. So I think that if we were giving prizes for most appearances on anniversary shows in the past year, you would get it.
I'd be in the running?
Yeah,
That's outstanding.
You'd be in the running.
Yeah.
So should we give this? No.
I could have some bridge mix.
I think your first appearance on the show this year.
I think so, yeah.
And I'm very excited because before the show, we were talking a little bit about the state of COVID in our community, and you brought some good news.
Yeah, it is good. So I was checking the numbers just before I came. So there's only one person hospitalized right now locally with COVID, which is
wow,
which is great news. And just to kind of frame a reference for people, a year ago at this time, actually the peak was the beginning of January. There was 95 people in the hospital with COVID.
Wow, 1 year ago.
So a year ago it was 95. That was our peak, and we're to 1 at this point. So that's great. And it's we were worried this year about not just COVID but also influenza. And that number I don't have exactly, but it's also very low. Both numbers have precipitously declined in the last few weeks. 2 weeks ago, we still had a few dozen people in the hospital with COVID, and so that's gone away.
That's interesting because the fear was with Christmas we would be exposed to so many people with holiday gatherings and going to concerts and church and everything, but it's not panning out.
Well, so that did actually happen right after. So right around New Year's and then beginning of January, we did have quite a few people, and it's tapered right off after that. So that time when people were gathering did have an impact. I think the thing people have to be aware of is, we've learned now that this goes in waves, right? It ebbs and flows. So this is really good news right now. This is the lowest hospitalization numbers I can remember since March of 2020. But that doesn't mean that we don't have a variant that changes and we see things tick up again. And so I think people still have to just be vigilant, and we know it's going to change. We know the virus is going to change. So
yeah, and it's still a dangerous virus. I know someone that just 2 weeks ago died in Jackson from COVID.
Yeah, we lost in January. It's the end of January now. So there was from the beginning to the end of January, there's 7 people in the county that died of COVID. So more than one person a week was still dying of COVID. So even though we're kind of declaring victory, it's gone. People are dying, every week. And I want to say the last count, there's something like 640, 650 people that died in Jackson County from COVID since the beginning, since they started tracking it. So that's pretty significant in a county of 150, 160,000 people.
Well, yeah, really, if you think about, if someone told us before the pandemic started that, there's going to be this sickness that's going to strike Jackson County, and more than 650 people are going to die in the next couple of years, we would have, I don't know what we would have done, but we would have thought of and talked about nothing else, and we would have locked all the doors or something.
We did for a while. But yeah, I think it's important to not kind of forget the toll that it's had on everybody. So, but it's a nice breather right now. I think that people at the hospital are appreciating a little bit of a break from things. There's been a lot of stress on people for years at this point.
When you consider nearly 100 people in the hospital a year ago with COVID, the stress on the health system and all the people working, we can't, those of us outside, we can't imagine what it was like. We've seen, little clips and little anecdotes, but it was hugely stressful, and a lot of people burned out right out of the health system.
There was quite a few people, folks, nurses, other kind of team members in the hospital that provide more kind of ancillary support type services in addition to clinical team members that especially people kind of right on the border, close to retirement, that they took it as an opportunity to get out. And not a criticism at all. It was just it was stressful for people and folks that had had a lot of years. I think it was kind of that was their time. But even younger people, our turnover of staff, new staff, is very high. New nurses, nurse assistants, things like that, because it's a stressful environment. The hospital's a high stress place. People are sick, so it wears on the caregivers, and so we've seen that in our turnover numbers for sure.
And you have contract nurses still?
We do, although thankfully that has declined on some level. So still needing them to help kind of fill in the gaps, but we've been more successful kind of building the pipeline of talent from local schools and things like that to help supplement with new nurses and things coming into the environment.
So the first year of the pandemic, the first flu season, no flu. Second year, still hardly any flu. And here, third year, we're still seeing flu, but it's not like it was pre-pandemic.
Yeah, there was a pretty significant pretty significant wave of influenza in Michigan, end of December basically, and then into January. Quite a bit of flu activity. So I actually think that this flu season this year, ultimately, in retrospect, will look kind of similar to years that were pre-pandemic. So we kind of went back to normal. I don't think there was this giant rebound like people were expecting, that we were going to have the worst flu season we've seen in 10 years or something. But I think there was a sort of average flu season, or at least so far. I mean, I'm saying we're like it's over. February and March are really still kind of technically flu season. So there's still some time, but we have seen the most significant peak really kind of quiet down.
Well, we stopped wearing the masks for the most part, which was, we now understand, prevented the flu transmission.
Well, that's what prevented the flu transmission. Yeah, I mean, I think that's what people, we still, by the way, in clinical environments wear masks every day. In clinic, I'm in a mask all the time, and I haven't gotten sick in 2 years because I wear a mask all the time at work. And I think that's something people need to really think about. It's not crazy to wear a mask in environments where there's a really high risk of transmitting something, right? Really crowded public places, things like that. If I get on a plane now, I just wear a mask, and it's not really a big deal. And I might be one of the handful of people that still do that, but that's a really kind of enclosed environment, or airport, something like, very public spaces. It's not unreasonable to wear a mask.
Well, and it doesn't draw, disapproving stares. People are accepting of it, and they get it.
It's fine. Yeah.
All right. So the other things going around, besides the flu respiratory, we've got the RSV, which is respiratory
syncytial virus,
and there's no cure for that. There's no treatment, and I know that because I had it. I had it for 2 weeks.
Yeah.
And it was very unpleasant. I don't recommend it. But we're not seeing as many of those cases.
That activity has died down too, and that is worse. That's a worse virus in children in the pediatric population, and so we've seen that activity, I think, go down as well. And what you're referring to in terms of treatment is there's things we do supportively, of course, in the hospital when kids get that sick, but for influenza and for COVID now, there are outpatient medications you can take. For influenza, it's Tamiflu, and then for COVID, it's Paxlovid, which still, by the way, I mean, like, just because we're having lower numbers in the hospital, people, especially people that are at higher risk, so folks that are heavier, have chronic lung problems, diabetes, heart problems, things like that. If you get the flu or you get COVID, right, or I should say if you get symptoms, you still really want to get tested because you want to make sure what you have, if it's something that can be treated. And getting Tamiflu if it's the flu, or Paxlovid if it's COVID, is really important, I think, in those folks. It really lessens the severity of the disease. We don't have a lot of the same tools we had before because the virus has kept changing. The monoclonal antibodies no longer available. The new variants are too different. The monoclonal antibodies don't neutralize it anymore. And there was another medication called Evusheld, which was for people that were very high risk, immunocompromised. Same thing, that can't be used anymore. So really the way to deal with this now is if you get it and you're in a high-risk category, you got to get to your primary doc to get a prescription for Paxlovid, for COVID, or if it's flu, Tamiflu.
And there's a window of time where the medication works.
Yeah.
And it's like within
It's really within pretty much within 5 days is, I think, kind of a good rule of thumb. Definitely for Paxlovid. The sooner is better, though, to be able to get it. You really want to, the sooner you get it on board, I think the more helpful it's going to be.
All right, let's talk about the other preventative measures besides the masks and all the other things that we've been doing. The vaccination, that's changed, and I think there's so many people are unsure of what's available, when's the next time to get vaccinated, what the vaccination is, because there have been some changes.
It's awfully confusing now, I think, even for me. I have to pretty much go, every time I think about it, I have to go to the CDC's website because it has changed so much and so frequently. I think that, so right now, the current recommendation from the CDC is that people should get a primary series, which is 2 shots, which people will remember we all kind of got a first shot and then a second shot about a month later, 3 weeks if it was Pfizer, 4 weeks if it was Moderna. And that's what's called the monovalent. So that's basically the original COVID strain, is what it's protecting against. And then there's the booster. And now, that booster used to be, it was that same vaccine, just you got another dose of it. And now because there's been enough mutation of the virus, there's this bivalent, which is more effective against the BA variants, the BA strains. And so the current recommendation from the CDC is everybody should have a monovalent primary series, 2 shots a month apart, and then 2 months later get a booster, which is this bivalent that is to address the newer versions. And there was actually a study that came out just last week, data from the CDC where they looked at the effectiveness of that original vaccine compared to these new bivalent vaccines. And the bivalent vaccines were significantly more effective. So somewhere in the 40 to 50% range, depending on the age group, more effective in younger people that have better immune systems and a little less effective as people age. But that 40 to 50% range is kind of what a flu shot is normally. So we're kind of in that flu shot effectiveness range, which I think is really good. And this is at preventing infection, by the way, like preventing symptomatic infection. This is not 40 or 50% at preventing hospitalization or ER visits or things like that. This is just from preventing getting symptoms. So that's pretty good. And I think what the FDA is looking at now is whether to update the protocol, so to speak, around monovalent primary series and then bivalent booster to we're just going to use the bivalent all the time now because it's mutated so much from its original strain that we should really just be using that version. I don't know yet what that means in terms of do you get 2 and then 1 or what the interval is, but I think in the next probably week or 2, we're going to see that there's another update to what the CDC is recommending.
So basically we're going to wait until the CDC says what we should be doing in terms of...
Yeah, I think so. But I think for folks even now, if they got a primary series even a couple years ago and haven't gotten a booster, I would really highly encourage them to get a booster because there's basically a 50% increase in effectiveness of that new booster compared to what the old ones did. So you don't have the same level of coverage unless you've had the new vaccine. And our vaccine rates, by the way, nationally in the booster are very low. It's like 17% or something. So of this bivalent one. So I think we really need to encourage folks that it's important to do that.
Because if we expect to see reduction in transmission and incidence of the disease, we need to get the vaccination level up closer to 65-70%.
Yeah, I mean, you're talking about this herd immunity concept, which I think is going to be really hard to attain with COVID because it sort of it changes so quickly. But but what'll probably happen, just like with the flu, in sometime late spring, early summer, there'll be a group that gets together and says, okay, here's the strains that we think are the most likely. And what's good is that these mRNA vaccines can be modified and manufactured so quickly is that by the fall, by September, we'll then be giving people vaccine that really kind of matches up with what the circulating variants are at that point in time. So, I think that's one of the things, people were kind of skeptical of these mRNA vaccines in the beginning, but I think they're proving to be really, really amazing technological tools to combat this and keep people safe that are really at higher risk.
And the bivalent, is that an mRNA disease?
It is. Yeah, it's an mRNA vaccine. Now there is actually, I didn't mention this, but there's really three options now. There's Moderna and Pfizer. Those are both mRNA. And then there's a third option called Novavax. Novavax is a protein-based vaccine. That's the same as a whole lot of other vaccines we already have. Like the tetanus vaccine is a protein-based based vaccine. And so some people feel more comfortable with that because that technology has been around a really long time. Mm-hmm. The end result is kind of the same. If you inject mRNA, your body's going to make the protein versus just injecting the protein. So either way, you're going to have spike protein, which is the part of the virus that attaches to our cells, and you want your antibodies to recognize that and be able to clear it from your system. But some people are more comfortable with having the protein vaccine, and that's fine. It works. It works too.
Well, I think we had too many choices. First, J&J, Pfizer, the numbers, it's just we had as patients, we had too many decisions to make where typically in past vaccine, here's the vaccine for this disease, take it or leave it, right?
Well, if it's confusing for the doctors, it's definitely confusing for the patients. Yeah. And I get questions all the time from people. They're like, which one do I use? What should I be giving people? And so if those questions are happening from other physicians, then everybody else is definitely going to have questions. But I think this is going to, as we're starting to see the data come out now, and the data from the CDC is very recent. It's from December and January. And we're seeing, I think, reasonable levels of effectiveness against the variants, against the BB and the X, sort of like X variants, XBB. So that's good, and I think that's gonna help simplify, I think, what the type of recommendation is and what vaccine to give people.
So, with your crystal ball, we've got right now one person in the hospital. Cases are down, or in the coldest week of the year. When things warm up and spring and summer arrive, can you predict where we'll be with COVID at that point?
That's very dangerous. So I think the one thing we've learned is that we have no ability to predict what happens with COVID. In general, COVID, just like the flu, is easier to transmit when people are in close proximity. And so it's not that in the winter that we all get, cold weather makes a difference, is that we're inside and together. And so we actually see something a little different in the South where people go inside in the summer because it's too hot. So it's the proximity to other people that is the problem.
And I think we've learned, we've just adapted. We stand 5 feet apart from people in the line.
Which works, by the way.
Yeah. Yeah. And I think we're not, for the most part, we're aware that we're maybe too close. We're in someone's private space, and I think we've just become better at it.
Yeah, I think that's right. Yeah, I think that's right.
Well, we appreciate you being here on all our big anniversary days. What are you doing tonight to celebrate?
I hadn't planned anything yet, but now that I have a birthday party to celebrate, I'll have to throw something together.
Well, we appreciate you being part of our 22nd anniversary.
Yeah, happy birthday.
Good to see you. Thank you. The Vice President for Population Health at Henry Ford Jackson Hospital, Dr. Courtland Keteyian. Well, as